Welcome, ladies and gentlemen. I'm Dr. Jatinder Bali, and I welcome all of you to the nationwide classroom Masterclass series. Today we have with us Dr. Rahul Mayer, who will be talking to us about tomography and its clinical applications. Dr. Rahul Mayer is a leading retina specialist of Delhi. He is practicing in Shroff Charity Eye Hospital in Daryaganj in Delhi. Over to you, Dr. Rahul.
Good morning, all. I am Dr. Rahul, and I am a vitreoretina consultant at Shroff Charity. So, I just wanted to take a short lecture on how to basically interpret OCT. So, I think for PGs and for fellows, it is very important to do that. To start with, I'll just go in to let you know that what we started with and what we are today. So, we started with the time domain OCTs way back in early 2000s to now what we are at the Fourier domain OCTs. So the differences, as you can see, the earlier OCTs used to acquire 400 A scans per second, whereas now the latest models of OCT acquire up to 71,000 A scans per second. The signal to noise ratio was very low initially, but now we have a very good signal to noise ratio. The axial length was extremely poor in the time domain series, but now with the Fourier domain OCTs, the axial length has improved drastically. So I think I need not go into the details of the structures seen on OCT. I think all of us know, I think this is very basic what we know from inner to outer, as you can see here. Just to let you guys know that uh, the what layers you see on OCT, the highly reflective structures which are shown with bright colors, that are the red and yellow. The low reflectivity are represented by dark colors, that are the black and the blue, and those with intermediate reflectivity are usually green. So as you can see, what are the greens and what are the blues and what are the yellows and the oranges. So this is how you see an OCT scan. Just directly coming to the OCT interpretation. So how do we basically interpret an OCT? So to interpret an OCT, we have to have these 5 things in mind when we are seeing an OCT. To start with, the vitreoretinal interface, the preretinal and the epiretinal, the foveal contour, which may be normal, which may be obliterated, which may be deformed, which may be flattened. The retinal morphology, that is the intraretinal and the subretinal. The RPE or the Brooks membrane integrity, and coming to the sub-RPE and the choroidal vasculature. I think with the latest OCTs, what we have, all the OCTs have the EDI mode. That is the enhanced depth imaging, wherein we can go to the choroidal structures. And retina is fast changing because of the invent of something known as pachychoroid. I think all of us know about it. So I'm just going as a case-based approach, wherein I'm going to show you an OCT, tell you about that, and how do we interpret that. So what you can see on your screen is a diabetic patient with 6 years of history of diabetes, 45-year-old female. What we can see to interpret it, we'll go from the vitreoretinal interface. That is, the vitreoretinal interface is absolutely normal. You can't see any membranes there. You have diffuse intraretinal cystic spaces. There is no subretinal fluid or a neurosensory detachment. The RPE integrity looks good. This is slightly lower. I won't comment on the choroidal structures there. So I'll just show you some of the findings what are seen in a case of a diabetic retinopathy. So a diabetic patient may present like this, wherein you can see that the foveal contour is obliterated. You have a large neurosensory detachment with a spongiform kind of edema all throughout. As you can see, the intraretinal cystic spaces are going throughout the MAC. Another presentation can be like this, where you have, as you can see, the vitreoretinal interface is getting pulled. So there is a vitreomacular traction at the fovea, which is pulling the retina up. causing this large neurosensory detachment at the fovea. What you can see towards the left on your screen are some ILM folds. These are the internal limiting membrane folds, which are very commonly seen in diabetic patients. This may be another presentation of a diabetic patient where you can see large cystic spaces, and along with what you can see is a dark yellow color, high reflective uh, uh, thing present there, which is having a backshotting. If I show you the color fundus, you can correlate that this is a hard exudate which is causing backshotting. So these are the presentations what we see most commonly in a diabetic macular edema, which may be a cystoid, which may be a neurosensory detachment, which can be a spongiform edema, a vitreomacular traction, or a macular TRD. So coming to another case, what we very commonly see in our clinics. So this was a 57-year-old gentleman, history of hypertension, uncontrolled, best corrected visual acuity was 6/60, and came with us with diminution of vision for a month. On the right side, you can see the color for fundus photo. I think nothing, no problem in diagnosis. So this is a superior temporal branch retinal vein occlusion to this patient. So coming to the OCT, what we can see basically is that the vitreoretinal interface is absolutely normal. The foveal contour is distorted. And what we can see is the edema along, which is corresponding to the superior temporal BR view. You have got a small neurosensory detachment also there. And the hard exudates, what you can see on the color fundus, are corresponding with those high reflective spots, what you can see exactly bang at the fovea. So nothing much. We gave an anti-VEGF shot to this patient. 2 weeks post-op. This is the photo. What we can see is the edema has started to come down. The neurosensory detachment has started to come. Another case very commonly seen is a CRVO. Herein, what you can see is basically a large cystic space with lot of edema at the macula. On the other side, you can see a large, went ahead, did an angiography for this patient. What we can see are areas of CNP, which confirms the diagnosis of a central retinal vein occlusion. Nothing, given anti-VEGF. After 3 anti-VEGFs, the fovea is absolutely dry, the edema is totally gone. We went ahead and did laser also for this patient because the later angiograms showed a lot of neovascularization temporally to the macula. So this was an interesting paper, which actually, when I started retina, I didn't know much about it. Wherein most commonly what we see is the cystoid macular edema along with subretinal detachment. That accounts for 45%. Only CMEs are seen in around 40% of the patients. And this was a paper from GNEC, wherein they showed that 15% of the patients may just show with a subretinal detachment. So this was something that only a subretinal detachment or a neurosensory detachment can be a presentation for an RVO. I think
Thank you, Dr. Rahul. I think we come to the end of this presentation, short on time. We'll carry it on in part 2.